Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. Okay, so today we're going to talk about a basic approach to the elbow radiograph. Like with all studies, the overall organization will start with looking at the history, indication, any sort of prior studies. We're going to take a look at the overall study technique, any limitations, look at the overall mineralization or kind of extent of abnormality as well, morphology of the bones, and then go through and carefully look for fractures, issues with alignment, arthritic changes, and then ultimately any other focal bone lesions or miscellaneous findings. Okay, so this is what a basic four-view of the elbow looks like. We got a frontal view, lateral, and then two obliques. This particular study was done in the setting of trauma. And as we go through, the first thing after you've done your homework, you understand what's going on with the patient, looking at priors across various modalities. You want to get a sense as to, you want to know how many views you've got. You want to see that the lateral is well positioned, the humeral condyles are well superimposed, that if there was a joint infusion, you could see it, that we're kind of got kind of the joint kind of centered on the image. And then, considering if we do see something that we don't really understand well, do we need additional views? And kind of getting overall sense of the extent of any underlying abnormality, if the bones, what is the mineralization of the bone, and does that impact how we can assess what's going on? If there's hardware, that's kind of like a first frequent step to look at and assess that for any sort of complication or failure. And then, the elbow radiograph is a pretty straightforward study, and we're going to go through, like with all other MSK radiographs, and look and trace every single cortex on every single view and just make sure that we're looking carefully for breaks, for irregularity, for lucency, for calcium formation, periosteal reaction, the usual sorts of things. Noting also that sometimes subtle fractures will see traversing the medullary or projecting over what we see as the medullary space. Kind of key considerations to keep in mind for the elbow radiograph is that particularly in adults, subtle fractures, impaction fractures can be seen at the radial head and neck. We just want to make sure that we're looking very carefully in our review, zooming up, windowing, etc., just to make sure that we are, being very sensitive, particularly in that region. In children, I won't go into kind of the gory details, but remembering the Krytos sequence, and particularly, the order and kind of expected appearance time of the kind of trochlear and internal epicondylar ossification centers is going to be particularly useful. This is, again, in adults, so this is going to be less relevant here. Both in adults and in kids, at least just having a sense as to, the radiocapitellar line, if that's well aligned, the anterohumeral line, and then looking at, the radiocapitellar articulation, the ulnotrochlear articulation on each view, looking to make sure that those are well opposed and that there's no, subtle abnormality there. You want to also remember that, in the setting of dislocation or various, kind of injuries, which kind of have like an impaction-like mechanism, that the coronoid process could be a subtle fracture that you want to be able to pick up in those sort of circumstances. All right. As part of like one of as an upper extremity, non-weight bearing joint, it's going to be, the degenerative changes are not going to be as common or as advanced here, but you do want to look for, the common things for osteoarthritic changes, joint space narrowing, osteophytosis, cystic change, sclerosis around the joint space, things like this. In kind of less common circumstances, you might see erosions, you might see other kind of inflammatory or other arthritic processes as well. It can be important to remember, at least as part of your checklist, and this may be more so in kind of younger populations, that you can, in some circumstances, see osteochondral lesions at the capitellum, which would be kind of a common place to see them when they are here. In children, I had neglected to mention that a lot, the fractures in kind of the younger age group will be through the condyle. So you want to be more careful there. But in any age group, we want to look for avulsion injuries. We want to look for any sequelae of traction processes, both at the medial and lateral condyles. And then as we're looking through the bone, generally you'll be able to pick up any, incidental, lucent, sclerotic, any other, focal osseous lesions. in addition to kind of the kind of more, the more characteristic distribution of osteochondral lesions at the capitellum. But just keep in mind that we want to just make sure that we scan all the osteostructures for any sort of abnormality there. And as we, wrap up the study, you want to make sure you're correlating across every single view and just being, again, aware that sometimes you can only see a fracture well on a single view. So again, that we have to just be careful and go through the search pattern for each single view. It could be useful to at least take a look at the soft tissues, though frequently, as with all radiographs, the soft tissues, unless there's, subacute air, radio-opaque foreign body, things like this, true soft tissue abnormalities can be less well demonstrated by radiograph. So, just as a recap, in terms of approaching the elbow radiograph, getting it's good to start, as always, with an understanding of the patient, prior studies, what the indication for this particular study is, look at the overall limitations, technique, understanding the overall morphology, mineralization of the bone, looking carefully for fractures, issues with alignment, looking for arthritic changes, and then finally osseous lesions, and then the soft tissues.